All right, so we're going to get our session started. I hope everyone can hear me. So good morning to our Canadian colleagues and good evening to our colleagues in India. And before we start, just send a message to our colleagues in India that our thoughts are with you during this difficult time that you're going through with the pandemic and the wave of COVID that your country is currently facing. And we hope that all of our colleagues and others and your family and friends are staying safe and well throughout this ordeal. Having said that, we're going to get into their session now where we're going to talk about artificial intelligence and its contributions to overcome COVID-19. Today's session will start with me by giving a brief overview and presentation of the topic area, including some highlights of the white paper that our esteemed group of panelists is developing in collaboration with each other. And then we'll have time to go through some Q&A and to hear from our panel members as well. Next slide, please. So as I mentioned, my name is Alex Militis. I'm a professor at the University of Toronto, and I've been conducting research in the area of technology to support older adults, specifically the role of artificial intelligence, robotics and sensors in the care of older people and to support their caregivers. I'm also the Associate Vice President for International Partnerships at U of T and the Scientific Director of the AgeWell Network of Center of Excellence, which is Canada's technology and aging network. Next slide, please. So here's a list of our esteemed panel members and the members of this working group that's developing the white paper. I won't go through each name, but as you can see, they come from a variety of different backgrounds and areas, and you'll get to know them more through my presentation initially now and during the Q&A session. Next slide, please. So let's get into it and talk specific about what our white paper is going to focus on. But I wanted to start kind of at a very high level. And I know probably most of you who are attending this conference obviously know what artificial intelligence is. But I want to start at a high level and then really hone in into what we are focusing ourselves. As we all know, artificial intelligence is really an umbrella term. It is an area of science and practice that includes a multitude of different areas, ranging from things such as of autonomous system, neural networks, pattern recognition, language processing, etc., as outlined on this diagram here. In terms of the work that artificial intelligence is doing in the area of COVID and to support the pandemic and perhaps more importantly and hopeful in supporting us all in a post-pandemic world, there are specific areas that we have discovered are starting to play a more significant role. Next slide, please. Specifically, one of the areas that you're going to see common throughout our topic areas that we're going to be presenting today in our discussion is the area of machine learning. Now, again, most of you know what machine learning is, but I want to just put it within the context of COVID and what we're doing. And these slides are presented and developed by one of our colleagues on the panel, Dr. Krishnan, who currently is with Microsoft Research, but soon will be starting at the University of Toronto as a professor. In terms of machine learning, as we know, one of the key aspects of this approach is collecting data from hospitals where patient data then can be linked to clinical outcomes. And by doing this, we can then design and train machine learning models that can predict patient outcomes. And this, as you can imagine, is really, really critical during this time of COVID. Next slide, please. So in terms of building the models, the key aspect obviously is the patient data and the training model that's being developed and also validating the model itself. And this is critical, obviously, because once the model has been validated, we can then deploy the machine learning models to predict a variety of useful outcomes, such as whether or not a patient needs to be admitted to hospital, readmitted to hospital, or even more complex approaches, such as whether this patient should be intubated or not. And obviously, we're seeing this as a big decision point right now during the pandemic. So what we're starting to see is a lot of people developing these decision-making tools using machine learning that help and support clinical staff when making the decisions about their patients and the type of care to be provided. Next slide, please. So one of the big aspects that COVID has obviously shown being a pandemic is it's not enough to be developing customized machine learning or anything in AI-based models for a specific person, but population level modeling has become really critical, not only in tracking the pandemic itself and COVID-19 and the various different variants, but again, also in terms of how to actually apply it in terms of making decisions for particular patients. Next slide, please. So building from that, what we're starting to see with in relationship to COVID-19 is the AI community itself has been looking at the variety of these techniques, machine learning and others, and really have mobilized very quickly when the pandemic struck. And what we found, and we'll talk about this a bit more later, is there's been some very large pivots sometime made within the AI world, where not only researchers, but companies as well and funding agencies have all very quickly directed the work that we've been doing in AI for other applications and domain areas and have applied it to help with the pandemic itself. And I thought this chart on this diagram was interesting. And this is the number of publications according to PubMed, that if you do a quick search, it is AI and COVID-19, you can see that very quickly from 2019, where there were 0 publications, within 1 year, there's almost 1,000 publications in this area. And already in 2021, not even halfway through the year, we're already seeing 800 publications that are out there in this topic area. So as you can imagine, this number will continue to increase. And I expect even post COVID-19, we're going to start to see a lot of publications continue in the area of AI as related to pandemics and other disease modeling. Next slide, please. So related to this, and as I mentioned, it's just not the academic world that's been really accelerating the role of AI, but we've also then been pulling in industry and the investment community, as you'll hear from some of our panel members. But COVID-19 has really accelerated the adoption of foundational digital infrastructure, which will in turn accelerate adoption of advanced technology such as AI that will really help to address many of the challenges emerging from the pandemic. So for example, we're seeing startup companies like Blue Dot, that's here in Toronto, that's helped to monitor and track the spread of the pandemic. We have AI-based CT scans and X-ray analysis that helps understand the progression of the disease. And I'll talk more specifically about that by one of our team members, Dr. Faisal Beg. Startups have helped to improve access to healthcare. So for example, we've seen an explosion, at least here in Canada, with respect to telehealth for triaging around mental health support, access to medical records, etc. And finally, AI has been instrumental in the development of many mRNA vaccines, as well as identifying therapeutics that can be used for treating COVID. And again, I'll talk a bit more about some specific work that our team members are doing in this area. Next slide, please. So I'm not going to go over this slide in detail. You can see the text here for yourselves, but obviously, all this has presented many opportunities and challenges within the AI field, and how to continue to develop AI solutions that are being implemented in healthcare settings that are specifically helping with the pandemic, but as I mentioned, broader healthcare issues as well. And if we can take any positive out of what's happened over the past almost 2 years with COVID-19, is the fact that the AI community really is embracing the difficult challenges, but also more importantly, the opportunities that the current healthcare situation is presenting to it. Next slide, please. So based on all this very quick background, what we decided to do is focus on 6 specific areas within the white paper that we're developing right now. So what I'm going to get into are some of the specific areas you see here that are topics are ranging from very medical-based topics to ones that are more social, and specifically looking at AI in the care of older people in long-term care, which here in Canada and other parts of the world has really become a big issue. We'll talk in our white paper and today about AI in imaging diagnosis, AI for disease transmission and modeling, which is becoming so important these days with all the different variants, AI in the acceleration of drug discovery. But then beyond those specific application areas, we also want to focus on how AI supporting small, medium-sized enterprises in the times of COVID, and also how the investment community has also stepped up to support many of the new startups that are coming out of various academic centers around the world. And then finally finishing off our white paper around, what does it actually take? It's fantastic that we've done all this work on AI and modeling, et cetera, but how do we actually take it and get it implemented? Not now just during the pandemic, but long after that as well. Next slide, please. So at this point, I want to give some highlights of what our team members are working on. As you can imagine, it's always difficult presenting other people's work. So I apologize in advance to our audience members and to our panelists if I fumble a little bit on what your work is, but you will have an opportunity to correct or to add anything to what I'm talking about with respect to your slides. So let's start first with AI in long-term care, specifically looking after people with dementia. And this is work being done by Dr. Shiroz Khan, who's here at the University of Toronto in Toronto Rehab. Specifically, Dr. Khan is focusing on, you can just stay on this slide, that's fine. Specifically, Dr. Khan is focusing on different types of behavioral manifestations from dementia, such as agitation. Agitation actually is one of the most common behavioral symptoms of dementia, and agitated patients can hurt themselves and other residents, and we're starting to see an increase in actual deaths here in Canada because of resident-on-resident violence or resident-on-staff violence. Current methods to assess agitation are just observational and retrospective, and more importantly, there's no prediction that can happen. Next slide, please. So what Dr. Khan and his team has been doing here in Toronto has been using multimodal sensors that have been installed in a long-term care unit here at Toronto Rehab. So specifically, he's been conducting a 2-year study at our specialized dementia unit where data from 20 people over 600 days was collected from various multimodal sensors. And this include a wearable, ambient sensors, and 15 cameras. And I remember, I'm not sure if we're still doing the wearables, Shiroz, or not, and you can comment on this later, because obviously there are issues when dealing with people with dementia. And I remember a couple of years ago, we lost one of our wearable devices, and we think one of the residents flushed it down the toilet, but that's a whole nother presentation that we can get into. So the wearable data shows that the multimodal sensors work better than a single sensor in detecting agitation in people with dementia, and hence why using these different types of sensors is so important. Next slide, please. So what we're actually gonna do here is show a video, and what you're seeing in this video, and hopefully it plays, is a camera was used to detect agitation in a non-invasive manner, where unsupervised deep learning models were trained on normal activities in the dementia unit and detect agitation as an anomaly. The agitation event was never shown to the classifier, but can detect it in the test samples as shown in this video that's running right now. The rise in score at the bottom that you're seeing in the graph shows when a patient hits another resident. So this is an interesting approach where typically what we would try to do is train these models on the adverse event or activity itself. But what Shiroz has done brilliantly here is actually has kind of flipped it on here and actually trains the model on normal behaviors and then looks for those anomalies, as you can see. Next slide, please. So as we quickly continue through our tour of our white paper, I want to move on to the next area, and that's AI for imaging and diagnosis. And this work is being done by Dr. Faisal Beg from Simon Fraser University, which is located in Vancouver. Next slide, please. So when an individual enters a clinic for treatment, let's say for cancer or for something else or a different type of surgery, then for the same treatment and surgery, the responses are widely different. If we can correctly predict ahead of time what the response would be to a clinical intervention, it can help to select the best treatment for the individual. And we're seeing that very much so now with COVID, as different types of treatments are being used. And because it's such a new situation, it's difficult to tell which treatment is best for the person. So specifically what Dr. Begg is working on here is looking at body composition measurements, namely skeletal muscles, subcutaneous, visceral, and intramuscular adipose tissue measured from the individual are important factors in clinical outcomes. So for example, toxicity, survival rate, infection, surgery, length of hospital stay, etc. Specifically, the skeletal muscle is an important prognostic factor for various outcomes, such as cancer, survival, and surgical outcomes. Next slide, please. Now, one of the issues here, though, is that for identical height and weight, SM mass can be vary substantially. And so variation in amount of SM for individuals with the same body mass index or BSA could explain the variability in toxicity from cancer treatment and the variability in surgical outcomes. So the field has converged to analyzing SM and fat measures from a single slice in the CT images that are routinely acquired in the clinic because it was easy to analyze one slice, and because from this 2004 paper that's being shown here showed that good correlation to the whole body measures. So by measuring all CT slices available for the individual, better individual prediction models can be made. The 3D renderings are shown at the bottom of this slide, show the richness of variation in internal organs across individuals, which is very likely a factor in the response of these individuals to their clinical treatments. Next slide, please. So if the individual is the main variable in the standardized clinical workflow, then the response of the individual to treatments and surgery can be better predicted with measuring not just 3D skeletal muscle, in fact, by also measurements from other organs in the body. AI-based automation enables us to go beyond the a priori chosen measures, such as muscle and fat, and analyze the full richness of tissues in an individual to predict how that individual will respond to the prescribed clinical intervention. So you can imagine the powerfulness of this approach. You can go to the next slide, please. That can really help us to predict the clinical outcomes for a new patient, thereby helping select the most optimal treatment options. And so while the slides and the work by Dr. Begg at this point is focused on other specific conditions, I'm sure you can all see the applicability to COVID-19 right now, and that is something we can ask Dr. Begg to talk about during the Q&A. Next slide, please. So we're going to move on now to Dr. Chandar, who's a scientist at Mila, which is the AI, one of the 3 AI institutes that's been set up in Canada, based out of Montreal. And his specialty is the use of AI in the acceleration of drug discovery. Go to the next slide, please. So a molecule is usually represented as strings or smiles or as a graph, where the node of the graph is the atom and the edge is the bond itself. And thus several advances in natural language processing and in graph neural networks in the context of supervised, unsupervised, and self-supervised reinforcement learning were leveraged to push forward the frontiers in drug discovery. So again, an example of how things that we've done in a different area of AI, such as natural language processing, has been applied in this particular situation as well. Next slide, please. So on this diagram here, what you see is the molecular design. So initially, genetic algorithms were used to design molecules. Recently, generative models like variational autoencoders and generative adversarial networks were used on string or graph representations of molecules, and they performed at par with GAs. It can also be formulated as a reinforcement learning problem where each atom/bond can be added or deleted at every time step. It was followed by synthesis pipelines where neural networks trained to predict reaction outputs were used to plan the synthesis pathway. To bridge these two disjointed pipelines, reinforcement learning algorithms were proposed directly on the chemical reaction space and are currently considered to be state-of-the-art for molecular generation. Next slide, please. So while representations like Morgan fingerprints or molecular descriptors are good enough for training simple neural networks to predict properties like QED or ClogP, SMILES, or graph representations were used for predicting molecular activities against the chosen target. So again, what you can see here is the applicability of this work in terms of how machine learning and some of the different approaches that Dr. Chandar described in his slides here can be applied in drug discovery that is oh so important right now around vaccinations and other drug therapeutics that may be required for COVID-19. And we look forward to hearing more from Dr. Chandar in our Q&A. Next slide, please. So while we have spoken about some specific examples, the question now really gets to, how do we actually now take these things and get them in the clinical settings? And as I mentioned at the start of the presentation, this will be a really important part of our white paper. So next, I'm going to be talking about the work done by CARING, the Center for Advanced Research in Imaging, Neurosciences, and Genomics, on the validation deployment of AI in clinical settings. And again, this is being done by our colleague, Dr. Mahajan, who is here to discuss his work during the Q&A session. Next slide, please. So while we all know that there are several AI algorithms that are being developed around the world and more being built every single day, it's also a fact that not many of them are being used clinically. And this is even still the case right now during COVID-19. In terms of why this happens, the slide outlines really three main reasons for this. First of all, there are just too many algorithms. There are hundreds of developers, thousands of researchers, and the question is, how do hospitals and healthcare providers even access these? Second, there is a trust gap between clinicians and AI algorithms and the AI researchers themselves, I would add, which can only be bridged by aggressive validation. Unfortunately, today, there's no easy way for doctors to test and thereby trust AI, but we're hopefully going to change that. Lastly, even if one is able to access and test AI, the process for deploying them in clinical workflows are extremely difficult. Since there are no standards, it is extremely difficult for vendors to be dependent on the work that's happening, and often what ends up happening is the solutions are very, very expensive. Next slide, please. So one hypothesis is the solution lies within an integrated platform. So the CARPL, the Caring Analytics Platform, built by Caring, is a single platform for the end-to-end development, testing, and deployment of AI in the clinical realm. It contains an AI marketplace, data management and search tools, annotation tools, a validation platform for AI, and a single deployment platform which can seamlessly integrate multiple algorithms into clinical workflows. Next slide, please. So we want to explicitly go deep into the process of validation. The image on the left shows a snapshot of CARPL's validation platform, which makes it extremely easy for clinicians to test AI on their own data and get clinical insights and summary statistics without relying on data scientists and engineers. Validation is critical to the adoption of AI because it helps determine the clinical utility and readiness of an algorithm, determine its optimal operating threshold, especially for classification algorithms, and also allows one to share insights about failed cases with the developers to improve the performance of AI in the future. Next slide, please. So now that we've talked about, well, what does it take to get things in? One of the big questions is how do we now support the companies that will actually take these findings from researchers and use these validation tools, as we just saw with respect to carpal and actually move them forward. And what we're starting to see more and more is the type of company that's taking these on are the small to medium-sized enterprises and startups as well. So Dr. Tiagi from Durham College here in the Toronto region in Canada has really been focusing on this particular aspect as part of her role at Durham College within the field. Next slide, please. So obviously, one aspect that we need to address is the global impact, economic impact of COVID-19. So major advanced economies, which comprise of almost 60% of the total global economic activities, are forecasted to operate below their potential output level until 2024. And we're definitely seeing that here in Canada. Geeta Gopinath, the IMF's chief economist, said the crisis can knock 9 trillion off global GDP over the next 2 years. The IMF also estimates that the global economy shrunk by 4.4% in 2020, a decline that is estimated to be the worst since the Great Depression of the 1930s. Next slide, please. So SMEs represent almost 90% of total businesses and over 50% of employment worldwide. In the US alone, SMEs employ nearly half the working population and generate almost 45% of GDP. However, while SMEs are major drivers of economic growth, they're also often more vulnerable to disruption than their more robust enterprise counterparts. The three major factors that determine the intensity of this pandemic's impact on SMEs are: 1, type of business; 2, financial fragility of small businesses; and 3, the duration of COVID-related disruptions. Next slide, please. So the major areas where artificial intelligence and machine learning have played a substantial role in enhancing the survival and efficiencies of small business are: 1, in conversational AI platforms; 2, AI in logistics operations; 3, AI in business analytics; 4, in AI-based digital marketing; and 5, AI to hire talent. Specifically, post-pandemic, computer vision technology is being largely used in industries such as mining, manufacturing, and food production. Cloud computing technologies are being greatly used by many corporations. Change in consumer behavior of shoppers has seen increase in the use of chatbots and recommenders. And finally, automation is also being accelerated using AI. So this is a good example, again, about how the work that's being done in a particular domain, in this case, COVID-19, the pandemic, hopefully will have a lot of applicability in other industries and help to not only support these industries individually, but help to move our economies forward as we come out of the pandemic itself. Next slide, please. So I want to finish off now and summarize on behalf of the entire team of where things are at and really what has to happen next. Next slide, please. So as I mentioned, moving forward, this pandemic has shown how a community of researchers can mobilize very quickly and how the AI community can pivot and respond in different application areas and domains. And this is going to be really important, as I mentioned before, as we move out of the pandemic itself, and we continue to pivot to apply our learnings and our algorithms that have been developed in the AI world to other domains as well. AI has shown to be a powerful tool to help access a wide range of health applications, whether there's a pandemic or not, and this is not going to change. I know here in Canada, the situation with respect to telehealth, for example, and autonomous decision-making support tools in health are not going to go away. They have now become part of our reality and now continue to grow. And that's important, especially as we move towards a connected world where the data that'll be collected, has to be used for something that's applicable in the real world. And that's something that really needs to be considered. What is going to happen with all the data that has been collected thus far related to the pandemic, and how can it help us to be more prepared if any future pandemics hit us as well? Next slide, please. So the final question then is, what do we need to get there? And we spoke about many things thus far, but our colleague here, Dr. Krishnan, I think has summarized very nicely. There's really kind of three things we need to be looking at in order to get there. So the first, obviously, is the legal perspective and also the ethical perspective of this. You know, we're collecting multiple different digital data, health data stores. How is this going to be used? How is it going to be shared across the world? And again, how is it going to be used in order to help us prepare for anything in the future? Data access, as I mentioned in that last comment, is going to be critical. Providing access to healthcare data and computation for AI and machine learning researchers in academia, and perhaps even for industry as well as our partnerships grow. Finally, and in my opinion, probably the most important is working together. We need to come out of our silos. We need to work with clinicians, nurses, and frontline workers to make sure that the data that is being collected is being interpreted correctly, and that domain expertise drives the research questions themselves. And that is going to be critical to come up with anything that's going to be useful, not only for COVID-19, but in the future as well. Next slide. So with that, I thank you for listening to the overview of our white paper. I hope this has piqued your interest and that you will now ask some questions of our panelists. And that also, once our white paper is ready, that you'll be accessing it and using it in your own work. So with that, let's open it up to the panelists, please. So as you see in your chat, the Q&A session has begun. Please send your questions into the chat. Before we get to questions in the chat, though, I would like to give all of our esteemed colleagues here an opportunity to add anything that I said about their research, to correct anything, and also to maybe extend some of the discussion towards COVID-19. So having said that, I'm just going to go across the people on my screen and start with Dr. Krishnan, please.
Hey, thank you so much, Alex. I think you covered a lot of ground in terms of just some of the challenges as well as what we need in order for machine learning to actually have an impact in the space. I want to speak to, I just want to highlight one of the areas that were mentioned in the presentation, which was about working together with domain experts. And one of the reasons that I think this just aspect of work is important is because the data that these models are often trained on, particularly the particularly clinical data, is often very, very messy. It's missing. There's a large degree of bias in how it's collected, and so working with domain experts is maybe one of the most useful ways to spend time thinking together about the problem, because that automatically gives you an insight into what the potential biases are and how any of the modern machine learning tools that you use have to actively correct for them.
Oh, thank you very much for those comments. So why don't we move to Dr. Tiagi, please.
Hi, thank you, Dr. Alex. You've covered it very well. And we all understand that small and medium enterprises really make up a very important component of our economy, and they really face the blow of pandemic. So with very little data available, they really had to pivot and used AI, which has helped. So you've covered pretty much everything. So I'm open to the questions.
Great, thank you. Dr. Mahajan, please.
Hi, once again, Alex, I think, presenting so many people's work, for the first time, you did a fabulous job. So I just want to highlight the importance of, essentially what Alex presented on my behalf, which is, this fundamental disconnect between the amount of work that is actually going on in AI and the amount of contribution that AI is having on the clinical side of things, right? In preclinical drug discovery, etc., it's really big, and there's no debating. So I think to everyone who's listening to this, either if you're a user of AI or if you're a builder of AI, remember that you are nothing without each other. So just drawing back to that same point around collaboration, unless and until we all as a community build the humility of going out and then asking people to find mistakes in our work, especially as it pertains to diagnostic AI, because there's still a bit of, you can go binary in diagnostics, right? Is there a disease or is there not a disease? So it's easy to find those mistakes. So unless and until you go out and find those mistakes, you will not be able to correct those mistakes and thereby not be ready for clinical deployment. So, and that's on both sides. It's on the clinical community to go out and give feedback to the developers, and it's on the developers to go out and seek that feedback. So yeah, so if we could all do that, maybe soon we have some of these tools in our offices.
Great, thank you for those comments. Dr. Khan.
Hi, thanks, Alex, for presenting on my behalf, and you did a fabulous job. Of course, you know this work very well, and thanks for highlighting that point about that expensive, very expensive piece of hardware that we lost, in our study, like $2,000 gone down the drain. We did not know, and that actually exposes some of the challenges. It's a challenge to work in a real world kind of situation, especially in a wild, in a non-controlled setting. So I think my 2 cents here is that the lessons that we learned from our work is that we should be, the AI community, I think, should be more taking chances and working more in the real world deployment of these systems. And I think this can be a good window to have the startup culture and develop these businesses around it. There's a great potential. And of course, it should, in my opinion, our work should be more focused on influencing or impacting the clinical practice and really, doing that solid work. Lastly, but not the least, from the researcher's point of view, I think one of the bigger challenges, and I actually like that slide where, Alex, you showed that, we have thousands of models, thousands of AI developers, but there's a great disconnect between both the AI and the clinical community in terms of the data. So in fact, this morning I was having some conversation with our collaborators from Europe, and one of the challenges, so they were asking me, can you share your data? And I was like, no. And it's not my personal opinion. It's because of the ethics and the privacy guidelines that they're strict, because we're dealing with sensitive patient data. So I think we need to develop those protocols around sharing data, at least in terms of within the research community. And I know Alex is doing a great job. I'm working with him on one of the projects where we have collected one of the largest data on fall detection, and we'll be releasing it very soon for the entire research community using multimodal privacy, computer vision modalities. So that's a very small step, and I encourage everyone to have those kind of things in their projects, so that the data can be shared for wider improvements in the field. So this is what I have to say.
Thank you, Dr. Khan. Dr. Chandar, please.
Okay. Thank you for the nice summary presentation, Alex. Well, I would just like to highlight like what Vidar mentioned. So I am a machine learning researcher, who is applying the machine learning techniques to drug discovery, as an application field, right? Well, of course, we don't, as machine learning researchers, we don't have all the fundamental knowledge about the problem itself. So that's why talking to domain experts is very important. And I think Alex covered a bunch of machine learning advances, which are extremely useful for the preclinical research, right? In finding the drug before the clinical studies. But I also acknowledge that there is not a lot of work that has been done by using machine learning during the clinical trials. But there is some work, so for example, people have used bandits to decide which drug is more effective in a clinical trial. But there's not a lot of recent advances in that area. So I think having more conversations like this, between people working in both the fields is extremely important, and there is value in knowledge transfer.
Great, thank you. And finally, Dr. Beg, please.
Thank you very much, Alex. You really summarized the slides so well that there's not much that's left to be stated. But I just want to say that I think one of the key aspects of AI in clinical medicine is AI is data hungry, and I think several participants touched on the fact that AI can do only as much as the data it is available to train on. Without the availability of data, AI is very limited. I mean, it cannot really get good insights out of it if it has not seen the range of variability available in the clinical real-world data sets. And those real-world data sets, as many participants also said, are very hard to get because of data silos that exist. And for good reason, privacy issues and security issues and ownership of data issues as to who owns the data. But eventually in the best outcome situation for benefiting society, we need to work through these issues and find ways of collaborating so that the data doesn't leave institutions, yet AIs can be trained on those data to learn from them and share the insights for the betterment of society. So I think that's really one very important point, democratization of access to data. The second is that we need translation of tools. There's a disconnect between scientists who are developing algorithms and publishing papers and the actual availability of those tools for end users. Because many times scientists are interested in novel ideas and develop proof of concepts, and the proof of concepts are left to languish in journals and never really make it out there in the clinical real world for testing. In fact, some of the best ideas that seem really good on paper might completely fail in real world testing also. So that disconnect needs to be bridged. And I think there's a need for a new generation of entrepreneur scientists who can actually combine the understanding of the real world and what the needs are of the real world, and take the best ideas from journals and scientific literature and actually build products. So this is really important. And I think that space is completely unfunded. In our national funding strategy, there's a lot of funding for science, for research, and there's funding for companies, but very little funding for these intermediate layer of scientist entrepreneurs who will develop and translate tools into the real world. And finally, for scientists, there's a lot of focus on us for producing papers, and scientists do produce a lot of papers, but sometimes the papers are great, new, novel, blue sky ideas. But at the end of the day, if those blue sky ideas don't translate themselves into the real world, then they just do not have as much impact. So I think, we also, as scientists, speaking for me as a scientist, one of the things I remind myself is, what is the impact of my work? What is the impact of the papers I'm generating? Is it really solving a real world problem? And so the focus is not just on writing a paper, but the focus for me, I remind myself, should be to solve a real world problem. So those are the three things that come to my mind as to how AI can benefit society in the long run. And it's important for us to seize the moment. AI is the new fire. We've invented a new way of looking at data, and there's a lot that can be done with it. So it's just the start. We are, working through the teething problems of AI and its applications in society. And I think there's a tremendous value that can be derived from this in the next few years and decades. So the future is going to be really amazing. Thank you.
Great. Well, thank you for those comments from all of our panelists. And again, for our attendees and audience, I encourage you to put any questions in the chat that you may have. I'm going to start off with a question, because the common theme that all of you spoke about, I think, was data, right? And the importance of getting the data and sharing data. Within the context specifically of Canada and India working together towards this problem, what are some ways that you foresee that we could actually start to have larger data sharing opportunities and perhaps even joint initiatives between Canada and India? And maybe I'll start with Dr. Mahajan, because I think you're the only one in our panel who's actually in India. in offering in India. So I think to get your perspective first, what could be done right now?
No, so I think it's a very easy answer. You sign a MOU between two organizations and you agree to share only anonymized data. You get ethics approval on both sides, and you go ahead and share data. Uh, I think the process is established. The implementation is where it becomes a problem. Like, let's say there's three scientists at the same institution in Canada, and working with a single institute in India. Can three of them leverage each other's documentation, so to say, to enable sharing of that data? Like, if you think of it, right now we've had two waves of COVID come and go, and we still haven't figured out sharing of data, right? We're now finally able to share vaccines, but we still can't share data. So I think it's just a process issue, and somehow we just need to uh, at a institute level uh, take a call. Somebody has to take a call, right? And get it done, and typically it falls on the IRB or the ethics committee to do that. But luckily with COVID, the at least in India, the ethics committees in India are able to meet on so-called emergency basis. So you don't need to wait for 1 month for the IRB to sit and go through your proposal and then approve it or not. It can be done in hours, literally. It's a smaller quorum that's needed, and all of that. So that's why a lot of COVID research actually got done, even in our organization. Um, but it's the answer is out there for us. It's just about speeding it up.
Anyone else want to comment on that? Okay, so why don't we now have a question from one of our attendees. I'll read it out. Thanks for the talk. I'm an undergraduate student from India. I had a quick question. We are an early stage mental health startup that are using machine learning to assist psychologists by predicting the real-time emotions of clients that are seeking therapy. Currently, we're testing it and realize that the machine learning model needs to be deployed in the smartphone with the app to ensure privacy of counseling. What are some ways we could run the machine learning model on the cloud, ensuring complete privacy of the user at the same time? Not an easy question. Who would like to provide some insights or thoughts on that?
Yeah, so maybe I can take this question, Alex. So we have been working on, like, in fact, me and Alex are co-supervising a student on mental health prediction using smartphones, and I'm also working separately on building these privacy preserving models on the cloud. So the most intuitive and straightforward answer would be to look for alternative models, like more decentralized models like federated learning, those kind of approaches. So the good thing with federated learning is that you're not combining the data of these patients or people or participants of your study. You're actually building individualized models and then combining their parameters. So in that sense, you are preserving their privacy, and at the same time, what should I say, like the side benefit is that you are providing personalization. So you can actually shoot two birds, with one stone, literally. So you can do AI in the cloud in a privacy preserving manner and then do personalization. So that would be your best bet if you want to work in the cloud space. Otherwise, there are other approaches as well, could be, but I think this should be the first line of investigation.
Great, thank you, Dr. Cohen. So building off that question, we hear a lot of these days around personalized medicine or personalized health. And a lot of people are expecting artificial intelligence to be part of that approach. How do we get to personalized health if we have to de-identify the data so much to the point where the personalization is actually lost in the models? Dr. Chandar, do you want to comment on that?
Okay, well, I think it's a very difficult challenge, right? Like so, well, like there is this field of like machine learning with differential privacy and so on, like which is slowly picking up, where people talk about like how to use examples, but like without preserving like crucial data from the examples, like for security reasons, right? Like well, I think also there is also a lot of push in the machine learning community for on-device learning. Like, so where the idea is like instead of pushing things to cloud, like can we come up with efficient learning algorithms, like which would learn on device? Like it could be the cell phone, or it could be like a small medical device that you have in the hospital. That like so if you can use all the personal information in an online fashion and like make predictions and then forget about the private information, then you are not breaching the privacy, right? Like but again, like on device learning is an extremely hard problem. Like so like 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 also the field is slowly moving towards like more and more sample efficient algorithms, like which are not data hungry. So hopefully like in 5 to 10 years, like we should be able to have algorithms which learn on device, like with just one or two examples, so that we can finally use them for personalized medicine, right? Like but I think we need to understand that we cannot do personalized medicine if you don't use all the personal data. So there's no question of like obfuscating the data, like so the model doesn't get the personal information. The model has to get the personal information, whether this is a male or a female, like what race and what's the age and so on, so that it can make suitable predictions. But like the challenge here is like how to do that on device, so that we don't send this to cloud, which could lead to like a lot of violations, right? Like so like what if someone eavesdrop the information when you're sending it to cloud, or like so what if the cloud service decides to save these data and so on, right? Like so these are fundamentally hard problems even for machine learning. Not just they're not just important for application, but also for the theory.
Great, thank you, Dr. Jenner.
Just to add, sorry.
Yep, Dr. Mahajan, go ahead.
Yeah. So, I think we also need, so 2 points, right? First is we need to break this conversation into, are we training a model or are we running inferencing? Right. So when you're training a model, certainly you don't have patient identifiers, right? So gender, age, weight, vision, even skin color, etc., are not identifiers, right? They are simply attributes. Uh, of course, if you start adding location, time, those kind of things, you start going towards identification. But so while you're training a model, certainly you can de-identify and even anonymize data and run it. And when you're running inferencing, if your question is as simple as, and we're using personalized medicine, right? Even today, in breast cancer, for example, if you have a BRCA mutation, you get this medicine called olaparib, which is that's personalized, right? It's precise. It works for people who have that mutation. So it's certainly happening today. That's the first point. The second point is around this almost obsession that we as the healthcare community have about finding faults in cloud and having this very anti-cloud kind of mindset. And it was a single statement that changed my personal apprehension. They said all of our money is on cloud, so what's the big deal with health data? Right. So it's about setting up the processes and the incentives to ensure that there is enough security there, that enables your data to be safely stored, right? Because Bitcoin is, God knows where Bitcoin is, whether it's cloud or what it is, but it's of tremendous value, and it's safe. So I think we need to change our thinking a little bit. And this single example changed mine.
So based on that, I'm going to move. Sorry, Dr. Khan. I'm going to move on to the next question. We only have 5 minutes left. And the question is, for aspiring researchers and inventors, how do you think our education and training programs will change in the future to ensure both domain experts and machine learning researchers work together more effectively? And maybe I'll ask Dr. Tiagi to start off, working within the college system, being very close to the educational program itself. What are your thoughts on that?
Absolutely. Most of the education programs that are being developed right now are being influenced by the market demand. So as we're seeing more demand of having, like, it started with data analysis and then integrating it, and now with AI and machine learning. So we're seeing more and more that is getting integrated into the education system, and more programs are being offered now for the students. And also amongst there's another scenario that is very, very helpful is that during the program, the students are being given the opportunity to work on real world scenarios. So by the time they graduate, it's incorporated in their education. So by the time they graduate, they are ready for the world, and they really know how to apply what they learn in the classroom, how to apply it on the real world scenarios, real world challenges. So this is what I've been seeing, this trend.
Great, thank you. Anyone else want to comment on that question?
Yeah, I can add to that. I think the thing that I tell a lot of the mentees that I work with is that it's not magic, and you shouldn't expect it to be magic. If you find that there's signal in the data and your model is doing something interesting, it's up to you to work with domain experts to figure out why. And I think that's sort of been a really fruitful way for me to work with domain experts in terms of understanding and deconstructing how the model makes its predictions. Because through that process, you truly begin to understand where the value in the model actually is.
Great, thank you. All right, so we have about 2 minutes left. So I'm going to ask one closing question for all the panel members. So this is, and I want you to kind of give a very quick answer on this one. And the question is, in your opinion, where do you feel AI has had the largest impact thus far with COVID-19? And you cannot pick your own field of research. Okay, I'm going to start with Dr. Beg.
Oh, I think AI has a lot of impact in identifying, for example, early signs of COVID-19 in chest X-rays. So that's something I'm aware of and familiar with. It's not my area of research precisely, but something related. So I think that has been quite impactful, but I'm not really sure how much of that is being democratized again, and whether it's available widely to be used worldwide. It's available in specialized centers, people who are willing to use that, but again, that's an issue of wider access. So that's one area that I'm aware of.
Thank you. Dr. Khan.
My answer is actually the same as Dr. Faisal Beg. I'm aware of some good work, in the early detection of COVID-19 using radiology and other, genomics and other omics type of data. So I think there's a lot of hope, and of course there are issues around data access and data sharing, but I think there's a lot of hope in drug discovery and things like that, vaccines and stuff like that.
Right. Dr. Jandar.
Well, even though as per your condition, I should not say drug discovery. Like I think there is a lot of impact in drug discovery and vaccine discovery, right? Like our current generation, drug discovery pipelines, like even though they are not completely automated by AI and machine learning, they have a lot of components which are because of the recent advances in machine learning. So I see that as a big impact.
Great, thank you. Dr. Mahajan.
So absolutely not my field, but I think at least in India, a lot of geographical disease prediction models have been built and used with plus minus kind of efficacy, but certainly I think globally, you mentioned blue dot as well, right? So the whole disease spread modeling has played quite a major role, I think.
Thank you. Dr. Tiagi.
I would say definitely these specific areas which everybody has mentioned, but I would say AI has made a very significant impact on assisting people in strategic decision making, be it drug discovery, be it scenario modeling or prediction, or in automation. Wherever AI has really assisted in making a strategic decision, bringing more precision and accuracy.
Great, thank you. And finally, Dr. Krishanan.
Yeah, so I'd say that, like, to take a slightly more controversial stance, I'd say that it hasn't lived up to the large degree of potential that a lot of people expected of it, and that's okay. I think that the success stories that we've seen are from being able to have developed a vaccine in under a year for a completely new virus is just an amazing advancement, and I don't think that any of that goes to AI in any way. But I would say that the pandemic is not over, and it's going to continue to exist in some form across the world in different countries. And so I'd say that there's still an opportunity for AI to have an impact. And personally, for me, one of the most exciting parts of research that I've seen that I think has a lot of promise is thinking about incorporating advances in causal inference into these models. And so whether it be from the perspective of identifying good interventional strategies so that disease spread is mitigated as much as possible, or understanding, which treatments might help patients avoid being intubated. I think those are both really exciting areas from a research perspective that machine learning can still have an impact in the pandemic as it evolves.
Great. Well, that brings us to a close on our session. I'd like to thank our panelists once again and all their hard work that they've done thus far on the presentation and the white paper. And with that, I'm gonna, let's see here, it says the session now over. Please head back to the main session program using this link. So thank you very much. I wish everyone a good rest of your day and a good rest of your evening. And again, we'll see you all tomorrow in our next session on artificial intelligence and COVID. Bye-bye.
Thanks again for moderating, Alex.
Thanks, everyone.
Thank you. Thank you, everyone. Thanks.
Talk to y'all later. Bye.